privilege to introduce Dr. Aparna Bhatnagar. She did her oculoplasty training from Julestein Eye Institute, California and Shankar Nethralaya, Chennai. She is currently working in Apollo Hospital and Sri Ramachandra Institute, Chennai. She is a great surgeon as well as a great artist. She has a bachelor degree in fine arts. A warm welcome, ma'am.
Thank you so much for the kind introduction. Thank you, Dr. Anju, for inviting me for this session. And I will start my talk by paying homage to our chief, Dr. Badrinath, who left us with this emptiness. And I pledge that we may carry on forward his legacy of doing ethical practices and service to the humankind. So my topic is past, present, and future of dacryology gadgets. I will not be taking or talking about more of a surgical interventions and procedures, but more of the gadgets or the tools that we use in dacryology. So the history starts with the first mention of lacrimal system in the Code of Hammurabi dating back to 2250 BC, where it was first described. The only part which was described later on was the swelling or infection of the lacrimal sac, which was mentioned in fistula in all cases. And the only treatment for this was to burn or cauterize the entire sac. Unfortunately, Renaissance was not that active in research in lacrimal system, and it was a little bit laid back. George Stahl suggesting probing for the first time using violin thread. And the first description of probing and syringing was demonstrated by Dominic Anal. So this is how a 18th century lacrimal and dental instrument tray looks like. They even had a silver spoon to cover the eye. Bowman probe that we use is not modified into what we do today. It's as it is, as it was described by Bowman in 1851. The first history or historical description of dacryocystectomy was laid out practically destroying the lacrimal sac. So it was not mentioned in a step-by manner. The morning DCT was described by Rudolf Berlin in somewhere in 1800s. As we all know, Totti described DCR and its modification in 1904, but interestingly, endonasal procedure was already described some 15-20 years before. So 20th century, yes, more of modifications and reconstructions and remodifications of instruments were there. Stenting materials from thread to suture to cannula, even putting gauze wicks were very common that time. And silicone intubation has evolved over a period of time. So in the benefit of time, this is a totally different topic to be discussed in another talk. Balloon dacryoplasty, as Sonam said, not much experience has been there, and we have done a couple of cases, but the success rate is very variable, and it is not a very, very friendly or very successful procedure. So this is what our current lacrimal instrument tray looks like. Apart from the major instruments that we still use, only hammer and chisel have been exchanged by rongeurs and punches. Rest everything almost remains the same. Endoscopes, yes, they are here to stay, originally used in gastroduodenal surgeries. And the basic part of the endoscopic surgery is the telescope, which has never been changed so far. It was described by Hopkins in the late 18s, and only modifications of the endoscopes have been there. So we have all different types and shapes of endoscopes. Then came the laser dacryoplasty. The only disadvantage with these procedures were the extreme charring or fibrosis of the tissues, and the recurrence rate was extremely high with these. The next came as micro-lacrimal surgeries using a micro drill. The micro drill, if you see, it is attached at the end of the endoscope, and it is used for post-saccular stenosis, occlusions, or removing fine membranes, or also debulking of dacryolids. Lacrimal canalizer, we use it by a different name, canalicular trephination, that we all still use. It's very easy, it's non-expensive, but people have tried using an electrical recanalizer. I've also included some imaging here because I feel that imaging is a part of the gadget, and it has intervened in our surgical procedures. I'll explain to you why. The first most favored among the conventional X-ray techniques was digital subtraction dacryocystography. And why we call it subtraction? Because it eliminates the background images, as you can see, and gives a very clear contrast-filled lacrimal image for the study. The second came as lacrimal dacryoscintigraphy, which was the first radionucleotide evaluation in the system. But if you see, it is done in real time, and the patient is asked to blink over a period of half an hour. So it's a time consuming, but the poor anatomical detail, the resolution of images are extremely poor, makes it a very uncomfortable and unpopular technique. Yes, B-scan mode, as Sonam said, ultrasonography, we have done a lot in the past, we still do, and especially for cases of dacryocystocele. Again, lack of anatomical details, inability to accurately localize abnormalities is the drawback. But this is our favorite. This is CT-DCT. I think everybody uses it a lot. And it's an excellent tool for bony structures around the lacrimal gland and bony windows. And now the three-dimensional reconstruction also shows us a little bit of information about the soft anatomical details of the lacrimal system. Likewise, they also tried MRI DCG, same as CT DCG. But then it is done in a real time, increased motion artifact. It is very difficult to instill the drop installation method once the patient is taken into the MRI room. So this is not very common, and the cost effectiveness is a drawback. The next is the anterior segment OCT. This we have started using in our institute, and it's quite helpful using or draining information about the proximal lacrimal system like the stenosis atresia. So with the help of infrared camera, which runs as a green line, if you can see, across the maximum diameter of the punctum, we take the OCT images. And what we see, it's very informative when we are dealing with punctal atresia or stenosis. So the ampulla is seen, is not visible, and sometimes it is present, but it is hidden by a pseudomembrane over the conjunctiva. So these are extremely helpful cases. The next is high definition siloendoscope. Siloendoscope usually is excuse me, referred or used for salivary duct pathologies. Some people have used as an endoscope for the lacrimal surgeries as well. This is another important tool or gadget, the conventional method and the high definition dacryoendoscope or lacriendoscope. This they say is pressure controlled, air insufflated. So they use compressed air instead of the saline irrigation that we use normally for the endoscope. And what they presume is that it yields significantly better image. So if you see image number A and B, the A is with the normal conventional air irrigation saline which is used, and the B is used with the compressed air. The images are much better. In the past, Dr. Hawate, if you have met Dr. Hawate, in the early 2000, he introduced a term called as a ERA DCR, where he introduced Hawate DCR electrodes for endoscopic DCRs. Ultrasonic endoscopic DCR is a very, very promising gadget here because it uses the ultrasonic waves, piezoelectric waves. So there is practically no charring of tissue, no burning, healing is excellent, there is no bleeding, and the dissection is extremely very smooth. This is the mainstay and the favorite topic of navigation in all our dacryology and oculoplasty conferences. Navigation guide, everybody talks about navigation these days. So what basically we have used the conventional Hopkins telescope, the endoscope is attached to it, and there are high degree resolution cameras attached to the endoscopy, which is done. So at our institute, we use this stealth navigation system, and the beauty of this is that the image which we encounter is in all the three sections, like you can see the axial, coronal and sagittal in the same sitting in the same window along with the endoscopic view. So what happens when you have an endoscopic procedure going on? We have these windows which are, you can see all the three sections along with the endoscopic view and along with the dummy probe, which is the red color probe in the fifth window, and you can actually go for a facial reconstruction in the same setting. So once you know you are in the right direction, absolutely spot on, then we can remove all the windows and carry on with the procedures. So there is, talking about the navigation, this is one step ahead of navigation, which is called as a look ahead software. So in look ahead software, we have the benefit, if you see these are 4 windows, and we have the benefit of anticipating the next anatomical structure which is going to be, or which we are going to face as our, during our procedure. So let me explain. This is the endoscopic view through the center of the lacrimal sac. So if you see, the first image is right corresponding to the endoscopic view. But the next 3 windows will show us the next anatomical structures which will come at the length of 5, 10 and 15 millimeter. So if you are contemplating an angular vein, or suppose you are contemplating major vessel, you can be guard yourself. The next is CT DCG. During the endoscope itself, you can instill the dye in the cul-de-sac, and you can do your surgeries along with the CT DCG in real time. Another advancement is if you have a 3D CT DCG, that is even better because it gives you a bone window and a soft tissue alignment at the same time. So lastly, just 1 minute extra. Future, as we are talking about, no talk can be complete without artificial intelligence. That is a must these days. So it's an umbrella term for all computer software based algorithms, and it has 2 components of AI, the machine learning and the deep learning. And while I was Googling AI and ophthalmology, I came across so many papers regarding AI in ophthalmology, but only 1 paper for lacrimal apparatus. The second and the last is the robotic. So any other talk will not go without the robotic thing. Robotic apparatus or positioning system, as we can see, and they have actually done in 3